RhodeMap to Sepsis Survival. Implementation strategy for SEP1 compliance on inpatient medical wards. Sepsis is a high morbidity and a high mortality condition, with 1.7 million hospitalizations and at least 350,000 deaths annually in the United States. Up to 50% of sepsis cases occur on medical wards or floors. When sepsis patients get admitted to the ICU from the medical wards, as opposed to the ED, mortality is higher for these patients, with one study reporting mortality of 40.3%. Therefore, sepsis on the wards deserves special attention since it is different from sepsis in the emergency department or ICU. On the floors, monitoring is less continuous, staffing ratios are different, and physicians are often covering many patients across multiple locations. Sepsis may also unfold gradually rather than declaring itself all at once. So the central problem is not simply whether clinicians know what SEP1 bundle is. A more useful question is whether the system is designed to reliably execute time-sensitive, life-saving sepsis care under actual ward conditions. That is the problem this study tried to address. This was a pre-post mixed methods implementation effectiveness hybrid type 3 study conducted in inpatient medical wards at a 719-bed tertiary care academic hospital in Providence, Rhode Island. The study was concerned with how to improve sepsis care with reliable SEP1 3-hour bundle completion in treating sepsis patients on inpatient medical wards or floors. After completion of a 6-component multimodal strategy, 3-hour SEP1 compliance improved from 21.8% to 38%, which was statistically significant with a p-value of 0.041. Through qualitative interviews with 15 providers, we found that both the RhodeMap to Sepsis Survival strategy packet and the SEP1 bundle had high acceptability, but adoption, fidelity, and feasibility were frequently constrained. Some significant challenges included cognitive overload, staffing, EMR friction, constant interruptions, competing administrative priorities, and the last mile of execution. The study was a mixed methods, hybrid type 3 implementation effectiveness study. In implementation science terminology, SEP1 was a clinical intervention we were trying to deliver more reliably, and RhodeMap to Sepsis Survival was the implementation strategy. There were 3 aims. Aim 1 was quantitative. Did SEP1 bundle compliance improve after the implementation? Aim 2 was qualitative. How did clinicians experience the RhodeMap to Sepsis Survival strategy in terms of acceptability, feasibility, adoption, and fidelity? Aim 3 was also quantitative. It looked at in-hospital mortality as a secondary hypothesis-generating clinical outcome. The study was not powered to make causal mortality claims. The pre-intervention period was January 2023 to April 2024, with 55 encounters. The post-intervention period was May 2024 to December 2025, with 92 encounters. RhodeMap to Sepsis Survival had 6 components. The first 3 were delivered throughout the post-intervention period of 20 months and included monthly performance feedback during the department meetings, monthly education with occasional case reviews, and visual infographic posters placed at workstations around the hospital. The next 3 were delivered only in the last 6 months and included a sepsis song, an EMR best practice alert, and a sepsis order set. The overall logic was to combine education and feedback with workflow tools because SEP1 completion is not just a knowledge task, it requires coordinated action across physicians, nurses, pharmacy, lab, EMR workflows, and documentation. This is the main quantitative result. The primary result, SEP1 compliance improved from 21.8% to 38%. This was statistically significant with a p-value of 0.041 and an absolute increase of 16.2 percentage points. The risk ratio was 1.74 and the number needed to treat was approximately 7. To be clear, this is not a mortality number needed to treat. This means that for every 7 eligible ward sepsis encounters in the post-intervention period, 1 additional encounter completed the full 3-hour SEP1 bundle compared with baseline. So RhodeMap to sepsis survival was associated with a statistically significant and clinically meaningful improvement in bundle completion. The qualitative section used Braun and Clark's thematic analysis method to analyze 15 provider interviews. The qualitative findings help explain the quantitative results. 125 codes generated were organized into 8 themes. The overall finding was acceptability was high, but feasibility and fidelity were constrained. Clinicians accepted the strategy, viewed SEP1 as useful, but adoption was variable. They felt the repeated education, feedback, posters, and the song all improved awareness. The EMR tools were viewed as important and in many ways indispensable, but also added friction. Clinicians also described major barriers: cognitive overload, constant workflow interruptions like secure chats and competing demands, alert fatigue, and staffing issues. A key insight was that awareness may improve, but reliable completion still depends on whether the system makes the right action feasible in real time. For the secondary clinical outcome, mortality decreased from 16.4% pre-intervention to 9.8% post-intervention. However, this was not statistically significant, and the study was not powered for mortality, so this should be interpreted cautiously. It is hypothesis generating only. The study shows improved compliance, but it cannot prove that RhodeMap to sepsis survival caused a mortality reduction. The main strengths are that this was a pragmatic, real-world study in an understudied ward setting, using a hybrid Type 3 design and mixed methods triangulation. The limitations are also important. This was a pre-post design without a concurrent control group and no randomization, from a single academic service, and with a modest sample size. Fidelity and exposure to individual components were not fully and quantitatively measured, and mortality was not powered. So I would frame this as pragmatic implementation evidence with no definitive finding on mortality. In conclusion, RhodeMap to sepsis survival was associated with a significantly improved SEP1 compliance on inpatient medical wards. But the deeper lesson is about system design. Implementation science should move beyond asking whether individual clinicians comply and towards asking whether systems are designed to make the right care feasible under real ward conditions. Thank you.
Sepsis suspected, investigated. Think of all you need to do. Sepsis, the patient has sepsis.